Hello everyone, and thank you for joining this NHS Providers webinar. For those of you who aren't aware, NHS Providers is the membership organisation for all NHS hospital, mental health, community and ambulance services. Today's session will focus on the impact coronavirus has had on mental health and how NHS trusts are responding. We're joined today by Saffron Cordery, Deputy Chief Executive of NHS Providers, and Angela Hillery and Melanie Walker, co-chairs of NHS Providers Mental Health Group.
Thanks very much, Kerry, and I'm really delighted to welcome you all this afternoon. This is the second Zoom parliamentary webinar that we've held during lockdown, and we found them to be a really valuable way of engaging directly with parliamentarians in their offices with a minimal of fuss, really, which I think is one of the new ways of communicating throughout coronavirus, which we hope continues beyond the virus once we move out of that. I think that one of the things that I really want to stress today is the fact that the story for mental health and community trusts on coronavirus and responding to COVID-19 is perhaps a little different than the stories we hear in the media about what went on in acute trusts on the front line. And I think it's really important that we bear in mind that coronavirus impacts all types of trusts, just as it impacts all types of patients and service users. And I think one of the bits that perhaps people aren't aware of is the fact that whilst in acute services and in ambulance emergency services, what we saw was a picture of coronavirus patient numbers going up like this, and then non-coronavirus patient numbers going down like this. So whilst there was a big fear about this overwhelm, what we saw was that not necessarily being balanced by, but we definitely saw the fact that fewer people were turning up at A&E departments, fewer people were calling ambulances, all elective planned care was stood down, and only the most urgent treatment was carried out. So I think that it paints a very different picture when you look at what happened in mental health trust, which was there were some changes obviously made to the nature of the service, and we did see in some areas that, for example, new referrals coming through from GPs were going down because the number of people turning up at GP practices was falling off. But actually, throughout coronavirus, there has been additional demand in terms of the levels of worry and concern out in the community, and also the fact that overall this has demand or use of services only fell away by 8%. And I think that is quite a stark picture when you think about A&E departments at the height of the pandemic losing around 60% of their demand and people coming through the door. So demand and how mental health trusts have dealt with coronavirus and what it means for them, I think, is a really important issue. Just a couple of other issues to flag, which is that all throughout the pandemic, of course, we know that trusts have been continuing to deliver their services, mental health trusts, particularly those who are also running community and learning disability services. Those services can't go away. They may be delivered differently, and we talked a lot in many arenas about how we deliver things through digital platforms, how we change the nature of the interaction with patients and service users. Some inpatients were discharged, for example, but it's a very different nature of treating patients, but they were still, those services need to be continued. So I think that's the first thing to remember. The second thing to remember is, of course, that the mental health workforce is just as vulnerable to coronavirus as any other part of the workforce. Therefore, all of the issues that were around at the height of pandemic around access to PPE, staff absence and illness, the need for testing are absolutely there in mental health trusts. And I think there was a real issue about actually prioritising mental health and community services for access to PPE at the beginning of this. And then the final thing that I'm going to say before I hand over is that it's really important to remember that when we're thinking about dealing with coronavirus, both now and kind of maintaining our readiness for the future, is is the state of the mental health trust estate, and whether buildings are really fit for purpose in an era of social distancing, trying to manage COVID, non-COVID patients. You know, we keep saying that COVID doesn't discriminate. Well, it doesn't discriminate in terms of whether people have a mental health condition or not, and whether they need inpatient care or face-to-face care. So there are lots of challenges out there for the mental health estate, which we know has been massively underinvested in over many, many years. So those are just some of the issues that have been coming to the fore throughout coronavirus and the pandemic. And also there are lots of issues ongoing that I think will just be exacerbated really by coronavirus. So that's enough from me. I am going to hand over first to Melanie. Melanie Walker is Chief Executive of Devon Partnership Trust. So let Melanie say some words first, and then we'll move on to Angela.
Sorry, had a technical hitch. So hello everyone, I'm Melanie Walker, I'm Chief Executive of Devon Partnership Trust, and we provide mental health and learning disabilities, not surprisingly, to the population of Devon, but also more widely, we have very specialist services for parts of the Southwest and one or two national services. So I think our experience, Saffron summarised very well the context. So Angela and I had a conversation this morning about how we might make sure we didn't either duplicate or miss things out. So I'll start, and then Angela, I'm sure we'll have her perspective too. But as Saffron said, it was a very different experience for mental health trusts than for acute providers or for primary care. And I think for Angela and I, our experiences are very different, because in the Southwest, the case rate was very low, whereas it's much higher in Angela's area, and she'll talk to you about that. So, however, we didn't know that when we started, so we all set off in the same way. And we, like everyone, had to work out what we were going to do. There wasn't really a template for it. So we made sure that we had prioritisation, so that the most unwell people, we were really, really clear how we would adjust their care, that they had check-in points, that we so where we could use digital technology to help, we did, but that wasn't suitable for everyone. So one of the issues Angela and I particularly wanted to talk about, and I think she'll pick up in some detail, is the issue of inequality and the consequence of that. So that is a driver for mental illness, but also the disproportionate impact then on people with mental illness of COVID. And as we come through into recovery with a recession, how that might impact too. So for our patients who were already known to us, we put in digital offers, and I can't underestimate, certainly, and I think this is true across. So we were probably one of the more digital immature organisations, to use the language, and we have probably delivered digital development in the space of 6 weeks that we assumed would take at least 4 years, if not longer. And so if I give you an example of that, there's a program called Attend Anywhere, which people use for outpatients. And we went from having none at all to being the second highest user of Attend Anywhere across the whole of the Southwest, including acute trusts. And what that meant was our clinicians could see people at home or in a way that suited them. So for us in Devon, the distances are huge. People have to travel for care, and there are very limited community resources in some parts of the country. And I know Bishop Malali's on, and she will, I'm sure, be able to talk about Devon as well. But so we undertook that bit, but also put in things like small teams of staff that would travel around to see patients. So people who needed a face-to-face contact, people who needed support, people who might need medication, etc. That was undertaken. In terms of our inpatient, we had to put infection control measures in, and all of that, we had to work at an extraordinary rate. And the challenges around the availability of PPE whilst the narrative was very focused, understandably, on acute trusts, was as challenging for mental health trusts. And if you then think about the consequence of having PPE on treatment and care, and the fact that all health services is people interaction business, but mental health services and learning disability services actually particularly so. If you are very mentally unwell and somebody presents to you with a mask on, the additional confusion and fear that might develop is quite significant. And also for our staff, the stress of not being able to do their job in the way they want to, because they're people, that's why they come and do the jobs. And some of the really imaginative ways they convey that. So their pictures on the side, they're making sure they have pictures around so people could see, groups on the wards to support people. And I'll finish in a minute so Angela can come in, because I very well could talk for hours about this and then poor Angela wouldn't have a chance and you wouldn't get any questions. But finally as well, the really important bit about supporting staff and how we had put all sorts of support in for staff, formal and informal. And in terms of our psychological therapies, so IAPT, which is we extended that significantly. We already had a dedicated access line for staff, but we offered that and are still offering that to all key workers across Devon. And at the moment, we're collating that information to give back and noting where in acute trusts staff are struggling and need some help so that we can get in behind them and support. So I think I'll stop there so and Angela can pick up and then we'll get into the debate.
Okay, thank you so much, Melanie. So over to you, Angela. This is Angela Hillery, who is Chief Executive of both Northampton Healthcare and Leicestershire Partnership. Over to you.
Thank you, Saffron and Melanie. So, as I say, try and touch on some of the things that are across both trusts that I'm leading, but also some of the elements that hopefully don't duplicate too much of what you've heard already. But I want to start by paying enormous tribute to staff. And I think, we heard that at the beginning with Saffron. I know Melanie's touched on it, but I cannot thank enough about how our staff mobilised behind what's been described. And just to give you a sense of that, we saw for the first time some new changes being introduced that included things like 24/7 central access points, so all age ability for people to contact mental health support during this period. That was really important and really significant in terms of being able to offer that in local areas. We also were very, very minded and still are very minded to support our acute colleagues. And again, in both trusts, we were able to emerge, I know in other areas they have too, what we call a mental health urgent care hub, which was very much trying to support our emergency departments to make sure people could get access. We could protect the acute sector very much at this time. We knew the modelling was anticipating high demand for their services. So we were able to think about how we could do things differently. That's something that I think a lot of areas have tried. We need to evaluate it, but certainly has made a difference. I know partners have been very supportive. We've also, as Melanie described, had to do a lot of work around infection prevention and control. And one of the trusts in particular, we had to establish isolation wards, which again lends itself to the point that Saffron's already mentioned is, in Leicestershire, I have dormitory accommodation, I don't in Northamptonshire. So those sorts of challenges around bed base, looking at, a state that's not fit for purpose is so important. And I couldn't be more strongly about the parity of the estate for mental health and making sure. I've got two trusts where it's very different indeed, and that is obviously significant. I think the other thing that I would just want to share is that initially we did see obviously an impact on referrals, and I think primarily this was a number of reasons. Obviously the COVID impact and fear and anxiety, which clearly was at play here, but we also see the impact of primary care and schools. And I think that was again a factor that we know is still being examined and explored nationally and locally, but certainly the impacts in those sectors do impact on mental health services, and we saw some of that and continue to see some of that. We also had initially less demand on our beds, but that was short-lived because we're now seeing increasing demands on our beds. And just to give you a sense of that, we are seeing people who, as Melanie said, we knew before, who we would anticipate may need periods of inpatient admissions. But we're also now seeing people who we didn't know. People who are perhaps having their first experience of psychosis, which again is COVID related. And that could be because they've had a secondary impact through relationship breakdown. It could be bereavement. It could be about the pandemic itself. But that is definitely significant. And to just give you a sense of that, in our psychiatric intensive care units in Leicestershire and in other trusts, I've seen a doubling of the numbers that we have coming through those particular facilities. So that gives you a sense of people who are very acutely unwell and the demand that maybe we're going to anticipate going forward. Now, at this point, it is difficult to give exact science around the demand that we're going to see in mental health. But I think, as Melanie described, we have absolutely kept services open and absolutely responded to referrals as we've had them. And again, pay tribute to people who are doing that. Digital innovative ways have been the ways we've done that. But I'm really worried about health inequalities, really worried about those people who we haven't seen yet, those people that are not known to services or haven't necessarily come forward into the service referral route yet. And if I talk about the health inequality lens, I'm sure you would agree with me that we're now going to, I'm sure, anticipate the economic impact that we know our males, our working age population are going to be significantly impacted upon. So again, we're starting to see some of those factors. It's very anecdotal at this point. I can't give you hard facts and evidence, but we have tried to drill down to some of the reasons for people coming into services. And you can see already that there are those factors emerging. So we can anticipate an effect, and whether we have the ability to support people in employment and with the wider determinants will be significant in mental health services going forward. And part of the health inequality conversation, I think, is a role for how we talk in the future about health and wellbeing boards, and how we think about the health inequalities agenda, and that it doesn't get contained in mental health trusts, which is what can happen at local level. So throughout the pandemic, I think one of the things that, again, mental health has been very, very positive about is we've done a lot of sharing and learning. And we've done that through a lot of national groups. I think this community is very, very clear that learning and sharing is the right thing to do. We're very generous with that, and I think that can only be good for the sector. So we've done a lot of that sharing and learning, and we do that within regional groups and nationally. But again, just to give you an example, in the East Midlands, we've formed an alliance between the organisations in mental health terms in that sector in the East Midlands, and we are doing that learning as we speak. So we're bringing people together to talk about what's happening, what we could do differently, what innovations, digital solutions we could find, and to talk about some of that demand and capacity as well. So lots of things happening. In terms of the other things that I would just want to finish off before we get into more conversation is the impact on children and young people. I think this is the hidden population, and we need to think about it like this. This is a group that will be impacted through schools, through safeguarding, domestic abuse, through unmet need. This is the really serious worry that I have, and I'm sure others do, in terms of what is happening in this sector and how can we work differently to support this sector, and how can we be clear in systems about what is happening and how we work together to make a difference. I'll leave it there, Saffron. Lots of food for thought, I'm sure, but conscious of questions.
Thank you for both of your introductions, and Saffron as well. We've just got one question that was submitted before who wasn't able to join, so I'll just ask that one before we open it up to questions from attendees. So they've asked, what innovations or reforms have your trust been able to push through during the pandemic that you're keen to be able to continue?
Okay, do you want me?
Yeah, Melanie, please do.
So I think we both touched on some of those. I think certainly for DPT, I think the probably the impact of digital was the most significant sort of facilitator of innovation. So I talked about the clinics and the inpatients, but we delivered therapy through that group and individual therapy. We provided social, so some of our healthcare assistants set up a Facebook social group, which was a closed group for certain patients, and the things that they would have normally done with them, they would normally have gone taking people for a coffee or taking so they could have a social interaction, which is a really important part of their care. They did that, so everybody had to be there at a certain time and have their coffee ready so they could do the coffee thing, those types of things. So they sound quite small, but they were hugely significant. And for we also, our ward rounds, so we had quite a few consultants who needed to shield, so but they still did their ward rounds virtually. And the other bit, I might not want to tell Angela this bit specifically, but we recruited a couple of members of staff from somewhere in the Midlands the week before lockdown, and so they worked their notice, I hasten to add, and it was a life choice, nothing else. But they came to, they obviously couldn't physically come, but they delivered their clinical services virtually from where they lived in the Midlands to Devon patients. And I think the second half of that question around reform, I think the opportunity of digital care to answer some of the rurality problems and some of the staffing problems is an opportunity. However, it has to be set in the context of it is an element of care, because there are some things that can be solely delivered by digital care, but it can't be the only intervention for many people. So I think those opportunities, and Angela's talked about the urgent care hubs, which we have done similar. And I suppose the reform around that would be just make it for us, seeing Angela's, would just be making sure that it's a positive development, not a reason to segregate people with mental health problems. And that isn't, I'm not suggesting that is what happened in Angela's or ours, but I think we could inadvertently do that if we weren't careful. So I think enabling the conversation about integration, but recognising specialism as well.
Angela, any thoughts to add from you?
Yes, I mean, obviously, the things that we've already mentioned about access points and urgent care hubs are new, and I think it's important that people understand that frame. But I think the other things I would add is obviously the digital communication with patients and carers, which I think has been quite different and very creative. But probably some other things that we would want to reinforce is our work with the voluntary sector. So again, pivotal, absolutely pivotal in terms of working with natural communities. And in our crisis pathways, particularly in Northamptonshire, where we've been able to keep crisis cafes open and use the voluntary sector, I would say have been very, very important to us. And we would want to convey that in terms of other areas using that sector, because I think, again, it lends itself to the social prescribing context, and whether we really going to embrace that as a society. I think it's got lots of opportunity around community assets, thinking about the models of care. So social prescribing would be one of those. And I think the other thing that I would just put into the mix around, which was quite innovative, was that we did a virtual wellbeing festival across a week for Northamptonshire, which was based around some work we've done previously as a trust. So we did lead in the system on this, but we'd always had a session a day once a year where wellbeing was a really important feature, and we did lots of taster sessions. We always had up to 400, 500 staff. But we did this across the whole system in a virtual means. And again, it was pretty ambitious and, you know, obviously quite novel. But it was really important as system leaders that we said that we wanted to value people and we wanted to give them a way that they could connect. And we used the week to bring people in, national leaders, to talk about wellbeing. And we also used staff to describe their stories and taster activities. And people could download and do it in their leisure, do it when they wanted to. So again, I think that was quite innovative, and I think reminds everybody about the importance of the role our staff have played. and continue to play. And as I say, it would be always a worry of mine that we keep that well-being of theirs centre stage.
Thank you very much. Thank you.
Okay.
Kerry, do we have the next question?
We've got one from Baroness Tyler, who I will just ask to unmute. Yeah.
Hello, can you hear me?
Yep.
Excellent, thank you very much. My question, I really wanted to pursue the point that Angela raised around health inequalities. I wondered, Angela, if you could just say a bit more about, first of all, the people who, if you like, you're not seeing and you're concerned you're not seeing, are people who have probably got existing mental health conditions or new conditions which have arisen as a result of the pandemic. I was also wondering if you felt there was a sort of a regional dimension to this, you know, some regional health inequalities. And finally, what you felt needed to be done in terms of a policy and practice response to get that really sort of joined up, holistic response, which is generally needed in terms of health inequalities, and who needs to be involved. Obviously, I was thinking of local authorities and others.
Yes, absolutely. I mean, it's you'll hear it's a passion of mine that we shine the lens, and we have to use this experience as an opportunity to, you know, one we wouldn't have wanted, but an opportunity nevertheless to say actually health inequalities are there and are significant, and systems and local areas need to be clear about what they are. And if we look at data, even before COVID, we would see they exist, and mental health would be absolutely one of those that we would be clear would emerge out of that data. We didn't need COVID to do that. But of course, what COVID's done is actually make more people who are vulnerable already more vulnerable. So the very nature of COVID and the impact means that we need to understand our health inequalities, but we need to understand the fact that those people are now more extremely in that zone. And the areas that I'm particularly worried about, but I'm not an expert, but the areas that I would share with you that I'm worried about, as I said, is children, young people in schools, those children, you know, who are homeschooled and are clearly not accessing school or getting the support because of poverty, you know, so technology has played a massive role, there's no doubt about it, but not everybody has access to the technology. We know that people and children and young people in particular haven't always had that access. So again, a hidden population, those people who are suffering in families because of increased pressure, albeit through economic reasons, be it through relationship reasons, be it through lockdown, as we're experiencing in Leicester now. Those tensions will create an impact, and we know children, young people, not least the working adults, will be impacted too. But I'm also worried about our BAME communities. And again, obviously, we're seeing this within Leicester City, where we are in a lockdown situation. We have increased positive rates of COVID. We know that these communities, again, have deprivation. We know there are areas of concern. So if we don't shine a light around health inequalities, then we won't have done what we need to do. So it's a really important focus. And I think the other one that I would say is that the other health inequality lens that we're going to need to be very explicit about is those people with no mental illness that we know already impacted in physical health terms around their ability to lead longer lives, quality of lives, long-term conditions that go with that. And again, the ability for systems to mobilise behind that is so important. My absolute mission would be, how do we look through mental health collectively as opposed to those who are commissioned or to deliver services? It's how do we do that together? And that's where I think health and wellbeing boards need to be pivotal and utilised more than perhaps they are in all areas.
Can I just add to that? So I would absolutely endorse what Angela said, and I'd just add two brief points. So the other group that I would add to that list that I think we need particular attention on is people with dementia. So those, so certainly we have noticed a significant increase in referrals for people with dementia, particularly those people who were getting on by, as it were, and then became isolated, if they didn't have family support and didn't have enough cognitive ability left to ask for help. So if they weren't known, then they weren't known, and the deterioration. And there've been 2 or 3 quite distressing stories about that. And we also know that that group were particularly disadvantaged in, or badly hit in, care homes. So, and they're a group that often don't, so we all talk quite a lot about dementia as a country, don't we, and worry that it's a big deal. But I wonder if we really looked at ourselves, how much do we really address that? And we know that whilst dementia is fairly indiscriminate in some ways, it is absolutely something that, both in terms of its presentation in BAME, learning disability and low socioeconomic groups, has a higher prevalence, but also the consequences of having it are felt even hard. It's hard, whoever you are, but your social capital, your estate, therefore what care you get and can afford, if you can afford at all, to supplement or by yourself. That's a huge group. And the other bit are those people who, I mean, trouble when you group people, but we certainly have noticed very isolated people on farms, in very rural locations, who get by a visit or 2 a week to a market or a shop that they haven't been able to do. They are tipping into needing support. And now, whether some of those people should have had a bit more anyway, and our phone, so Angela talked about the 24/7 offer, which we've all put in, and it's a physical offer and a phone offer and a digital offer. And our phone calls for people who don't really fall in the need for specialist mental health services, but are looking for support of some kind, it has shot away something like 40%. So it's those groups as well. And to Angela's point about how do we work with communities to look after each other, and make sure the people who need support, even if they can't articulate that themselves, are supported.
Thank you. Thank you. Should we have the next question, Kerry?
We've got Baroness Barker.
Hello, thank you very much. One of the things that I do is I sit on an advisory panel for Rethink, and Rethink have done an initial survey of some of their clients, and they've come out with a whole raft of really interesting findings about what the position was like in the experiences of people in secure units, not least the fact that many of them felt safe during the worst of the pandemic, and they were also incredibly grateful to the staff for continuing to come and look after them. But the questions about the estate and the acceptability of the buildings do remain. Still having communal wards was perhaps something that people could put up with. Not being able to go out for fresh air really was not. So there is a whole set of questions around that. I happen to belong to a group of people who've been largely were ignored in the 5-year forward plan, and that's the LGBT community. I don't think we see ourselves as being at the front of any queue anytime soon, and yet we are becoming more and more aware of needs within our community, which will probably need to be best addressed by our community. And I think what we're going to need is, in part of the redesign, not just looking at technology, but looking at how both in the acute sector and the community sector, we develop much more partnership working. Just one interesting point. You talked about children and young people, and I'm sure you're right. But there is a strange good news story. Mermaids, charity that works with young trans people and their family, actually their young people have got through this a lot better. Why? Because they didn't have to go to school and put up with all the stuff that really does their head in every day at school. So I think I would like to see is the more we get the capacity to be quite granular about different communities' needs, and we look at put that together with new routes of service delivery, we actually think there's quite a potential for some quite interesting change.
Yeah, I mean, I agree. I mean, I think you make a really valid point around, you know, the LGBTQ community is as important, and as you say, lends itself to some of the health inequalities that we know are equally there. So I would absolutely concur. I think the ability for us to be able to look at populations, and don't like the word, but segment is what, I can't think of the word at the moment, but the ability to be able to understand and stratify populations is important, because we need to make them very personalised and individualised, but we do need to understand the needs of different populations and be very much able to co-produce with them, I would suggest, what and how we design services. Because as you say, there are examples out there, quite rightly, where people have benefited, and there are lots of benefits we want to lock in. And we shouldn't assume it's a general approach, and I wouldn't want us to convey that. But it's really important that we work and co-produce with our service users and our communities about what is the art of the possible, what can we do differently. And if we don't create the ability to look through a health inequality lens, then I'm not sure everybody would necessarily recognise what we're recognising here, that that's essential.
Mel.
So again, support what Angela said. I was going to give a couple of examples. So in terms of your comment about secure services, so in our forensic secure services, we put a huge amount of additional support in, and but we have a very active patients council there, and we handed over to them, obviously safely, but they had a virtual Glastonbury, which was fantastic actually. But I think so those things are great and really important, but one of the particular challenges for that group was the fact that it's challenging enough to be locked in, and then when your leave has to be restricted, which is, you know, it's the most important thing when you're a secure patient, that became quite challenging. And actually our secure wards, it seemed to be easier, I'm not sure if that's the right phrase, but on our acute wards, which are locked to protect people in different ways, and people can come and go depending on why they're admitted. Actually the biggest, so that was probably where we have the most challenge to the restrictions, but because I think the people in forensic services just know they can't go where they want to go, and they're used to that, they were already used to that. But the biggest biggest friction, which we had to work really hard with staff, and staff were brilliant about, and patients got alongside, was the issue of smoking or vaping, which is, so actually it helped in the end, although it was a bit of a journey to really cut down on some of that. So there were benefits to it, but it was quite challenging. And to your point about the LGBTQ communities, absolutely. And we are really clear we need to do more. We have had virtual Pride this week, and in that we've started a dialogue about what else should we do in order to support people, and trying to raise a discussion that isn't led by managers who think it's a good thing to do, but is led by people from those communities, and so that we can engage, as you say, Baroness, in the way that people choose us to engage as much as possible.
Thank you. Kerry.
Oh, sorry, I'm mute. I think we've got a question from the Lord Bishop of London. No, sorry, Roswitha?
Oh, hello. Yes, thank you. Hi. I'm a child and adolescent psychiatrist, and I actually work with Baroness Tyler. Both Angela and Melanie mentioned kind of the rollout of digitalisation earlier, which in my own trust I'm aware of too. But I really am concerned about patients for whom that is not appropriate, not effective enough, and also for those who just don't have the access to it or can't use it. And that's, I mean, I think there has been a great celebration of digitalisation, but it's just not sufficient for many.
Yeah,
Melanie.
So absolutely, and that's when I'm saying it, I think Angela said as well that so digitalisation has had huge benefits, but it certainly isn't an appropriate tool to use for everything, and we didn't, and we won't. And what we did was assess every patient so that we were clear if it was appropriate, and that included a discussion with them. So those patients who either didn't have digital access, didn't want digital access, or weren't well enough to manage entirely through that format, that didn't happen for them. I think it ties in with the inequalities discussion because of the issues which you'll be very aware of digital exclusion. And I think if we really want some of the learning and look at the socioeconomic impact, then actually looking at the access to digital means for everybody as a way of actually developing the country, I would suggest, but perhaps I'm not allowed to say that in my role now, but that actually how do we do that? But we did also see some benefits, and you will understand this much better than me. So, for example, in our services for young children and young people, I think as the previous questioner said, we had a lot of young people who were so much better for not being at school and being able to use digital media to engage with their therapy. But actually we created, and working with the voluntary sector cohorts, social interaction for them. And they actually had much more social interaction during COVID than they did outside. And that was particularly true for some young people, also very much not true for some young people with autism. So there's, I think one of the things we've got to do is see there's a therapeutic environment of which digital enablement is important, just as Angela absolutely nailed the quality of the physical environment. And if we had both of those at a really high standard, and neither of those have been significantly invested in mental health for years. So I'm going to a meeting tomorrow from my neighbouring acute trust, who I do love with my life, and they're great partners. But I've got to sit and listen to their big digital programme, which costs several million, tens of millions, and I'm asking for 5 million because I haven't got it to interface. So I think there is a parity. So we talk about parity about how people are treated, and that's right. But there's also a parity of investment, which I think Angela said earlier, actually, and a parity of consideration and prioritisation that I think would make a huge difference. So sorry, it's a bit of a hobby horse of mine. I'll stop now. Go on for hours.
Angela.
And I would concur, this was certainly not a blanket approach that meant it was the means through which everybody was accessing treatment. It was a very individual approach, but there's definitely some benefits, and we've got to go on and evaluate the effectiveness and make sure that it is meeting people's needs and where we'd want to lock that in and where we wouldn't. So I think you're absolutely right. We wouldn't want to portray in any way that it is a blanket approach. But the bit that I think we just again need to remind ourselves is that a lot of primary care has gone digital. Yeah. And actually, it is a referral route through to mental health services. So we do need to understand that digital route as well. And the point that you're making about it's not the preferred route for everybody is how do we make sure that primary care also remains inclusive and doesn't exclude or consider the fact that digital could do that. And that's something, again, I think we've got to explore further.
Thank you. Kerry, can we have the next question, please?
Yeah, we've got another one from somebody who couldn't join us today. And they've asked, what does the pandemic experience mean for the ambitions in the long-term plan around mental health and its deliverability overall?
Who wants to?
You go first, Angela. I'll think of my answer while you're doing it.
I think very, very cohesive around the long-term plan for mental health, and the elements that I've touched on before about 24/7 central points and the access points and urgent care hubs and access for CAMs, all things that we're very, very much behind the mental health community. And there's no doubt that this pandemic has given us some acceleration of some of those elements. And that's because we've been, in many ways, empowered to act as providers, been able to mobilise and to put in place what we think has been needed for local systems. So it has been one of the positive effects of COVID. Having said that, we are all now need to be confident about securing sustainable resources and funds to meet. So obviously, we're in a position at the moment where we are receiving some COVID income, and we can put some of this cost around that. But obviously, the mental health investment standard, making sure that investment in mental health, as Melanie's already alluded to, continues to be replenished and understood, and absolutely an equal partner in local systems, then many of those benefits may not sustain. We hope they will, and we will continue to push for that. But obviously that's something that is down to more discussions at regional and national level.
Yeah, I would absolutely agree with that. And my plea to my system today was, so you think it, so they were being very nice, so I'm a bit ungrateful, but they were being very nice about the progress we've made, which is great. And my challenge back to them was, that's fantastic, you need to pay for it now, because what we've done is fast-tracked a lot of the long-term plan and evolved it, and it's sort of an in-the-moment thing, and that's been really exciting, and it's felt quite freeing, to be honest, about how we might move things forward. So one of the things that would be, I would suggest, so the mental health standard is fantastic, and certainly our commissioners, we haven't even had to debate it. We get it, there's no debate, but we're starting from a long way back. So we've got some more money, and we've, so the digital agenda, we've done 4 years work in 6 weeks. So that money would have been spread across time. We pulled that forward. Some of the things we've had to do, which we didn't know, so all the PPE, for example, or the infection control measures, we didn't know. So we've had to do that. So how do we make sure that we haven't diverted resources, which actually we all go, great, we've got this far, but then we're held because everybody else is playing catch up. So I suppose my plea, particularly, I think Angela articulated really well what is very, very clearly coming our way. So while we don't have evidence, direct evidence, we know from Christchurch in New Zealand after the earthquake and post-conflict evidence that there will be some sort of mental health impact, and it will be over and above our normal expectations. And the amount ranges from, I think, the lowest, well, obviously 0 would be the lowest amount, but there will be some, but up to 30% increased activity. That seems quite high, but we don't know. So how do we manage that on budgets that were already low? And that doesn't all need to come to providers. So if you think about Angela's point about inequalities, if significant money was invested in people having good jobs, good houses, social interaction, care and support, then we wouldn't need quite as much. I'm obviously not going to say we wouldn't need any, because we would need some, just to be clear. But actually, how do we make sure that we've got that as upfront as we can, so that we can keep that pace? And that, in my view, would drive closing the gap more quickly than anything else. And I might suggest that if we can find money for all those Nightingale hospitals, then we might be able to find some for mental health trusts.
I like your edginess, Mel. Angela.
I would only agree. I mean, I think that we need to make sure that there is a level playing field here, and that's not because we want it for the sake of it. It's because of what we've just been talking about, is that we already know people in our populations are not getting access to what they need. If we think about council services, we know the access is not sufficient. So we know that, and now we've got COVID, and we know the impact is going to be. We've got evidence that can tell us about, as Melanie said, previous experiences that we know we can anticipate and start to put some working assumptions on. But we just need to make sure that mental health doesn't become and remain a poor relation. It's got to be absolutely centre stage for people. We've got to have the investment, because this is the future. It's the future of our children, young people. It's the future of our working population. It's the future of how we actually manage in communities. So my plea would be, let's make sure that we can all understand that, and the conversations are happening everywhere, not just in these types of forums, it's everywhere.
Thank you. Thank you. Kerry, where are we at on the questions?
We've got one more from somebody that couldn't join us today. So they've asked, what areas do mental health services need most support around right now? And that could be from their local MP or from government. And then in the sort of medium and long term, where do they need support?
We've mentioned something already. Definitely resource around our estate. We're going to keep mentioning that because it's been really close to our hearts, and this is not just about estate for estate's sake. This is about actually people being treated in the right conditions who are very acutely unwell. So I think that's something that I think we'd all echo, that has to be delivered. We've got some good sense of that, but we want to make sure that that remains and is secure going forward. That's very important. I think, as we've mentioned before, is that we need to make sure that what we've managed to accelerate through the long-term plan through COVID is sustained, and that we can build and anticipate the growth in demand and plan for that through resources, be it with communities, be it with local providers. But we do need to make sure that we can and do plan together in local systems. I think one of the things that, as I say, I would want us to be clear about is the opportunity to use this around health inequalities and understand where our resources currently being spent and how can we use this experience to think quite differently would be something that I would want to leave people with. Thank you.
Mel?
Yes, to what Angela said, really. I think the more that people can see so be clear about what needs to be done to support the mental well-being of the population, but we do tend to end up in a either or conversation in a way that you don't about acute general services. So it's not either or, it's both. So we have some very unwell people now, and we know we will get more of them. The drivers of mental illness are generally not the week before. They have a long history. So how do we focus on improving the services now and investing in those, but also investing in young people's lives, in jobs, in work, all the things that Angela was saying, so that we support the population to be better mentally well in 5-10 years' time. This is not a short order. This is a long-term gain.
I think just to add is that what we don't want in trusts is to be seeing massive demands in our bed and admissions. We want to put the early interventions in. We want to put the preventative services in. We want to make sure that people have to come into a psychiatric inpatient stay unless that's really needed. Of course, if they do, we want that to be available in a good quality and in a good environment. But we don't want that. We want to prevent that. So again, that will take investment in local services and communities being able to work in an integrated way.
Thank you both so much. And I think with the questions, you've ranged across a whole host of themes there, not just what arises from coronavirus, but actually the challenges that mental health trusts have been facing day in, day out. And I think that what we've seen across the board with COVID-19 is the fact that it brings everything into sharp relief. And, we've seen that across every sector, and it's no different in the mental health sector. I think one of the things I'm struck by is the interdependence of all of the bits of the public sector, the third sector, the private sector. None of us can work in isolation. And I think that we've seen that so clearly during coronavirus in terms of the actions of individuals coming together to provide support as well as statutory services. But I've been really struck as well by the importance of the voluntary sector. And in particular, I think we need to be really concerned about the future of the voluntary sector, given that charitable giving has just plummeted. And we know that the long-term sustainability of a part of the system, which is so vital, particularly actually for mental health services, where there's a lot of engagement with service user charities and others, that I just think that we need to really be so clear about how dependent we all are and how interdependent we all are. So having taken chair's prerogative there, I am going to draw today's event to a close. Thank you so much, Melanie. Thank you so much, Angela. And thank you everyone who asked the question or who just listened in. I hope that it's helped you understand a bit more about what's going on the front line in mental health services, both during and beyond coronavirus. And I'm sure that we will be holding more of these, so please do stay in touch with our public affairs team. But thank you all very much.